Sorry.
Okay. Hello, everybody.
Yes, Ivo.
Hi, everybody. Good morning.
Hi, Ivo. This is Ted. Thank you for joining us.
Good morning.
Good morning.
It's my great pleasure and honor, Ted, to be with you in this morning session. Sorry about the delay. I'm here with Dr. Concha from DEDEF, with Dr. Dujcinova, and also with all our team to show you the case that we have chosen for this session.
Thank you very much, Ivo. And we have a nice audience here for you.
Thank you. Thank you once again for inviting us to share our experience. And we are prepared. In fact, we have done several steps before starting the broadcasting. And we can tell you something about the case if you want.
Surely, that'd be fine.
Okay, I would like ask my assistant to turn the screen and the camera to go, the camera to show the CT in the right, yeah, like this. The right panel is showing the case of abdominal and iliac aneurysm, and with very tortuous iliac arteries. In fact, the patient is a 61-year-old man after aortic valve replacement with mechanical valve and ascending aorta dilatation, still not aneurysm, but he had during the follow-up period this abdominal aneurysm followed, and because the aneurysm is symptomatic and there is an increasing into the diameter, we decided to cover with stent graft.
Yes, Ivo, we have Dan Clare and Patrice Bergeron and others here on the panel, so they may want to chime in at one point at a time and ask you questions. So you continue to present your case, and we'll watch it. Thank you.
Definitely. We are waiting for your questions, suggestions, and everything.
So, Ivo, based on this scan, what was the initial plan to treat this patient? How?
Okay, well, we decided to put a flared leg on the left side in order to seal the aneurysm, and because the distal part of the right iliac aneurysm is more or less suitable to seal with not flared iliac leg, we decided to use this three-part system of electronic and Durham, and with the help of Dr. Conchar, who is our proctor about the Medtronic device, we decided that the case is suitable for Medtronic Endurance system. We have a pigtail from above, a pigtail from the radial artery, to have the comfortable angiography from above, in order not to change anything on the level of the femoral arteries, just to handle devices.
Ivo, this is Patrice Bergeron. Let us know what you decided for the two hypogastric arteries. What your plan?
On a first intention, we decided not to cover both hypogastric. We have discussed a little, especially on the left side, if it will be possible to seal the aneurysm without covering the left hypogastric, and we decided that it will be possible. In fact, we didn't open yet the left side flared leg. So in case you advise us, we can even cover the hypogastric. I think that it will be possible not to cover.
Ivo, this is Dan Clare. What's the diameter of the iliac arteries on the left and on the right?
Okay, on the left side, the diameter of the aneurysm is 24, the biggest part, the widest part, and we have a flat leg that is 24. So it's fitting very well. It is fitting very well to the widest diameter of the left aneurysm, iliac aneurysm.
So, Ivo, you plan to seal at the middle part of the common iliac arteries, right?
Absolutely right. We are planning to open the distal left iliac leg just before the ostium of the hypogastric.
Okay, Ivo, I think if you can go ahead and proceed because we don't want to lose all of our satellite time.
Okay, we are proceeding. In fact, we can show you the step-by-step what we have done until now. And we're going to see, let's go step by step. Please, my assistant will show you the procedure since the beginning. Okay, this is the preliminary angiogram, the first one. Let's go next please. So this is the main body. We introduce the main body from the left side. And okay, this is the introduction of the main body. Go ahead, next. So this is the main body opening. Next. You see the opening of the main body of the endurance stent graft. Next, please. So this is the control angio just before releasing the main body. Next. Go next. Next. I will ask you after that what to do with the left renal artery stenosis, but it's a matter of discussion maybe for a second procedure. Next.
Can you hear me now?
Okay. This is the opening of the. Yeah, this is retrieval of the cone. Next. Next. So it's very well seen here that the patient is after a mechanical valve implantation of the aortic valve that is functioning very well without any problem. Next. It's and this is the introduction of the from the right radial artery. This is the introduction of the pigtail from above. Next, please. This is the the contralateral leg insertion of the wire. Next, please. And this is maybe the pigtail, verifying that we are within the lumen and not outside. Next. Okay, this is the pigtail, rotating the pigtail within the lumen of the graft. Okay, next. Once again. Next, this is the angio before putting the right leg. Next. Here is the right leg opening. Next. And we can show you now angio just before opening the left side iliac graft, and discuss what to do to cover the hypogastric or not to cover. Like this. Okay, we are injecting now. Не дишай, моля те за малко. So, I think the right side is quite acceptable. So the hypogastric is open. and we have to decide together, with your advice, to cover the hypogastric on the left side or not. But I mean that we can save it. I think that we can save it.
It does appear from this image, Ivo, that you can seal above where the distal aneurysmal segment is to exclude the abdominal component.
Okay. Roadmap. I will do a final roadmap now, and we will proceed with the final openings of the left. Okay, I'm proceeding. I'm proceeding, rotating, not pulling. Rota. Okay, we'll see. Okay, we're retrieving now the nose. We are going to put a 40 French sheet now in order to balloon. Okay.
Ivo, did you make groin incisions or did you do this percutaneously?
Okay, we did the groin incision. In fact, we have just limited experience with the closure devices, and we preferred for the live case to be on the safe side.
Dan, what size diameter of the iliac below the graft would you leave it and be acceptable? And when do you think you have to go down and take some technique to close it?
I think this is probably the upper limits of what I would accept. And I think in this situation, because you've preserved the other hypogastric, if you've achieved good seal, you could stop here. But this is obviously something that's going to need to be followed over time. And if you needed to, it could be embolized and extended later or just covered later, depending upon the anatomy. Many times I look at this as though if this were an aneurysm I would treat independently, then I try to treat it. But a 2.2, 2.4 centimeter aneurysm, I normally wouldn't be treating those. So we'd try to leave that if we could with this type of technique or something like that.
Daniel, the fact that he has an approach from the top, from the humeral, he can also, in the same time, prolong to the hypogastric and another graft to the external artery coming from the down. But it's another option.
He could do that, except he's from a radial artery, which would make that almost make it very challenging because of the diameters. But that's another method of dealing with this. And if access from above is already obtained, obviously that would make it easier to deal with here.
I mean, can I just make an observation? I mean, he's only 61. I think leaving a 24 millimeter common iliac artery aneurysm for surveillance over a long time is not without its own risks. Preserving internal iliac artery is probably welcome also. I think it's definitely one that looks, within the limited information available, suitable for an iliac bifurcation device. My experience is only with the Cook one, which appears to work reasonably well.
And would you agree that with the current stent graft in place in the common iliac, you sort of limited your options for an IBD graft in the future?
I don't know of a technique that would readily allow us on license to preserve that internal iliac now. Improvised techniques are possible, but it's making it unnecessarily difficult for future.
You know, placing a bifurcated stent graft in the iliac artery from a previous stent graft is very difficult. You know, I don't know how for the contralateral side you can do it. I should not advise this kind of.
Ivo, can you speak to us now and tell us what your thoughts are?
In fact, we are going to do one more picture, one more injection with a little more contrast. But I think that the aneurysm is quite well isolated, and there is no endoleak. We are going a little caudal. Okay. We are proceeding now with the injection. Volume ne diši za malo plete.
Having seen this angiogram now, let's just ask the audience, how many in the audience would leave this aneurysm and think about coming back at a later time? And how many would want to treat it at this particular time? Half and half, I think. Okay.
Half and half. Okay. I have heard the vote. So I think the main body and the right side is quite acceptable. On the left side, I think it's always possible to put an additional stent graft on the level of the iliac aneurysm. And in case you agree, our intention is to leave like this on this level, to follow the patient very strictly, and in case there is active and increasing in diameter left iliac aneurysm, to add stent graft just covering the distal part. What's your opinion?
The audience was pretty much mixed here, Ivo, so I think you have some latitude in how you go about this. We're almost at the end of our airtime, and I just wanted to say a word about Ivo Petro and Sofia, the city hospital there. I had the opportunity last year to go for the inauguration, and I can't tell you how impressed I was by this facility. And they've done a unique situation, I think. Some others may have done this, but partnering with a corporation, the GE people, so that they were able to have the latest equipment. And it really was a wonderful opportunity. And Ivo should be congratulated on putting together a superior team, and they do really hundreds of cases a year. Ivo, we thank you very much. We'll give you an applause, and we'll be seeing you a little bit later.
Thank you very much. Thank you a lot. Thank you, Ted, for the nice words. Thank you.